So, hi everyone, this is Shanti, one of the co-organizers of Let's Talk USMLE, and we are back after a really long break, and we're looking forward to giving you more exciting and informative webinars from now on more regularly. So, we hope that today we have planned a very interesting session, and we hope you have several takeaway points from this, and you'll be able to utilize this information for your own USMLE journey. We have with us Dr. Adarsh Tangella, who was recently matched into internal medicine at MedStar Washington Hospital Center. He'll be sharing his own USMLE journey. He'll be talking about the intricacies of match, and we'll also be willing to take questions towards the end. So feel free to ask any questions that you may have about USMLE or the whole match process in general, and make use of this opportunity. Along with that, we have with us here today Dr. Vinay Jaha, who is a third year internal medicine resident at University of Missouri, Kansas City. He's also recently matched into GI fellowship. And we have with us Dr. Pasya, who is the founder of Let's Rock USMLE, PG
Yes.
Piven at Kansas University Medical Center in neurology. Hello, Dr. Jaha, and hello, Dr. Pasya.
Vanilla, do you want to go first?
Yeah, hi everyone. Thank you for taking time out of your schedules. I know it's a Saturday evening and Saturday morning in India and here respectively. So I hope we make it worth your time and look forward to have an interesting conversation with others. Thanks, others, for joining us today.
Uh, Thank you so much for actually giving me the platform because I mean, right after the match, you got a lot of questions and you try to answer a lot of them, but it's easier when you get a platform so that you can, disseminate the information easier to everyone, whoever needs it. So Sai Kumar has been my friend for years, and thanks to him for giving me this opportunity to talk. So yeah, Sai Kumar, if you want to go ahead
Yeah.
and talk.
Okay. Nice to see you all guys again here. And it always gives us pleasure. The whole point of this initiative, Let's Talk USMLE, or talking about the USMLE match year ago, 1 year ago when we started this, Vinay and Shanti and I was very excited about mentoring and helping people as much as we can in this USMLE process. And due to some reasons we couldn't do it in the last 6 months, but we hope we'll continue to do this consistently from now on. And it again gives us immense pleasure to help the future applicants and be of a little help in this USMLE journey, in your USMLE journey. And as I mentioned, as Adarsh mentioned, he's been a friend of mine for last, good friend of best friend of mine for last 8 years, and it gives me again, I feel very uh, immensely excited about having Adarsh here as a speaker, and I congratulate him again for matching into internal medicine in DC, which I know means a lot for him, the city and the program. So congratulations again, Adarsh.
Thank you so much. Yeah, it does mean a lot. I was obsessed with the Northeast for the last 1.5 years. I wanted to settle out in New York or DC, and somehow I ended up in DC. So things worked out. Um, so do I go ahead and start with the presentation?
Yeah, I think we can.
Okay. Just
Okay. Meanwhile, while Adarsh is doing that, I'll give you a rundown of what we have planned for you today. We have a 30-minute presentation by Adarsh. He'll talk about his personal experience as well as include the how abouts and what was different during this year's math cycle and what would that mean for the future applicants like you guys. And he said try with best to give the information from this current year's match compared to last year's and how things changed. And after that we have around half an hour Q&A. I think we already got a few of the questions from the Google Forms link, and after we answer those questions, we'll have a Q&A session in the chat box. And if after the presentation and after that Q&A session, if you still have specific questions, feel free to include that in the Q&A. But I would recommend waiting until then because Adarsh is anyway going to answer many of the questions during his presentation itself. And even after that Q&A session, we are planning for a 1 hour session to have respect for everybody's time here, but we can extend it for 1 hour, 50 minutes, something like that. But after that, if you still have questions, Adarsh will be on Instagram takeover tomorrow, and feel free to ask him questions, bother him as much as you can. Tomorrow, he'll be available probably all day. So we'll see how
Yeah.
it goes. But I think others can start now.
Anyway, TLDR, my main intention for this presentation was to make you understand the match which I have experienced. And it is a very subjective experience. So take what you could relate to, question what you feel is not right. It's completely up to discretion and, for discussion. So I essentially put this slide up because all of us started off as Courage the Cowardly Dogs when the match began. All of us were very apprehensive. But courage wins at the end of the day. Whatever happens, he makes up some way or the other and wins at the end of the day. So most of the presentation is going to be inspired by Courage the Cowardly Dog. Not so cowardly dog, if I'm being honest. So this is a brief introduction. I finished MBBS in 2021. I finished my steps after graduating. So to all the people who have questions about observerships and applying for the match only with observerships and no electives and stuff, I can probably get your questions as well. Most of my rotations were in 2023. So I have about 2.5 years is my year of graduation, and I applied for the NRMP 2024, and here we are at the end of it. So I wanted to start off with a brief introduction about how I felt when the match was about to begin and before the match. There are a lot of difficult questions for me to answer as to where do I want to settle down? Do I have a geographical preference? Do I have a program preference? Do I want to talk about fellowship? Do I want to talk about future preferences? How will community programs take them? Of course, my family and my friends have been of really good support. So support system was never a lack. Financial support system was never lacking in this process for me. So for me, the biggest question was, do I make my CV lean towards the fact that I want to do a fellowship or not? Because that's a debate which a lot of people have, whether community programs or smaller programs, which usually take IMGs, will take you or not, especially if you want to apply for competitive fellowships like GI or cardiology. Both of them are been extremely competitive in the last match. So these are the usual questions we have, and usually the emotions with which we start the whole match process. Um, so So how much is too much when it comes to your graduation? Usually there are two sets of cutoff years. There are 3 years and 5 years. How do we know this? It's you have to go and do the program research. So usually some programs have a year graduation cutoff of 5 years. Some of them have 3 years. Some of them take if people have finished residencies across in different countries, or let's say in India, they consider the 3 years as clinical experience, and some people don't. Some people consider it as beyond their year of graduation. So that's a completely program dependent criteria. And as far as I have seen, a lot of the mid-tier to to the lower top tier programs which take IMGs usually do give importance to residencies. They do not neglect it because it is practical experience. Let's say, for example, in my program, two of the new residents who are joining us have finished residencies. One of them in India and one of them in Iraq. So. If you ask me, most of the mid-tier to lower top tier programs do consider residency as your clinical experience, and they do not neglect it. How do you group programs? They just usually two broad groups, which have a cutoff for 3 years and which have a cutoff for 5 years, which I already talked about. This was the topic which I got a lot of questions on after going through the Google form questions. It was primarily about electives, observerships, and letters of recommendation, how to get them, where to apply. So there are basically three ways which I understood you can get United States clinical experience. One is if you're a medical student, you can, and your college has VSLO, more than happy, you can just go through it. But unfortunately, a lot of colleges do not have it. So there are a set of colleges, I think, which you can bypass VSLO and apply as well. Let's say I think Yale has one of those opportunities, Cornell has one of those opportunities. But all of these are student electives. And I'm not exactly the right person to talk about student electives because I started the whole process after graduation. But more or less, I've dealt with observerships, which also involve a lot of paperwork and submitting and all that stuff. So these are the observership opportunities which I came across while I was looking for them. University of Miami, Drexel, Cleveland Clinic, KUMC, Sunny Upstate. Upstate actually even has subspecialty observerships right now, and it's pretty decently priced if you ask me, for a great opportunity, because they also have an in-house IMG friendly program as well. And I think recently, if people are following LinkedIn, a lot of people have come up with USC lists where, electives, observerships, and IMG friendly programs which offer observerships. I tried to find them, but somehow I couldn't find them. But if someone finds them, please do share. Please do send it to me on LinkedIn, because I really want to send it to not just. I just want to share it with other people so that it'll be very useful, because finding observerships is one of the biggest trouble. And how do you get free observerships? Usually, the best way is to approach your alumni if they're there in the institute. That's the easiest way. Let's say Sai Kumar once just randomly texted me that one of my college alumni was a HEMONC specialist at KUMC. I immediately emailed her with my CV, and she said, "Sure, hop on. We'll do something and we'll get you on board." So your college alumni are usually the most useful support system, but it's difficult to find where your college alumni are, especially as assistant professors or associate professors. So that is one way, which is better than random cold emailing, which is the second option. You just go on cold emailing random places, and if one or two people might respond, might not respond. But we are in AMC, we are trying to establish a recent graduate alumni group in the who have finished residencies or in fellowships in the last 10 years, so that we can be more helpful for our juniors. Um, Maybe something like that might also be helpful for the next batches, because more and more people are giving USMLE these days, and more people need help. LORs and observerships. Uh, if I'm being very honest, there's not a lot of difference between the letters of recommendation a lot of us get. It's not like someone gets a extremely glorious letter of recommendation, someone gets a very mid-tier recommendation. They're very subtle differences, and they just don't look at academics or medical knowledge as your only criteria. Being on time is and expressing curiosity, and I think one of the most important factors which I felt was, showing interest in shadowing them in the morning. When you go at 7 a.m., you're not lazy, you don't just sit down, you run with them. And you just, ask them for questions, you ask them for references, how does this treatment work, how does that there's no dumb question. You can ask them anything. It's not like our system where you get judged left and right. You can ask them any kind of questions. And one more thing which I wanted to tell about is whether 4 US LORs or 3 US LORs in one home country LOR. This is a confusion a lot of people. This is a question which a lot of people ask me. What I did was 3 US LORs and one home country LOR, because I thought something has to be representative of my 3 years of learning something in Vizag. So that's what I did, and it worked out pretty decently well. And your standard letter of evaluation is not compulsory for a lot of programs. I think probably 2 or 3 programs ask you for that. So it's not a compulsory thing. If you have it, it's good. If not, it's okay. Research and so another question is how to get research positions is what I got. Usually, this is the time when a lot of research scholars leave their positions. That mostly, I think, are in Mayo. How do you get them? You have to find the PIs of the programs from which the person is quitting. Or if you have your college seniors who are quitting from that position, then you have to ask them. They're going to recommend you, because that is going to work much better than randomly cold emailing people. Um, Paid versus unpaid research positions. I think a lot of the research positions available for IMGs unfortunately don't start off as paid positions. Even in Mayo, I think the first 3 months is not paid, and then they start paying after that. They're like different ways and to approach it. Um, and how do you get remote collaborations is, I think, one question which I got. Remote research opportunities don't need to be associated with the PI. You can just collaborate with your friends and other students who are interested in the same batch and come up with ideas. That's how a lot of people that's how a lot of PGY3s collaborate with different people from across different programs. You don't need a PI for remote collaboration. You just need to have an idea and 10 people who want to work and who have experience already. How do you find them? LinkedIn is the best source. Just post, we have a certain idea, working on so and so area of medicine. If someone is interested, you can definitely hop on or send your CV. Um, and one more thing is usually what do PDs look for in research? You're just beginning residency. Do they expect you to have RCTs in your CV? No. So they basically need to understand whether you know research methodologies, you know how to review literature, you know how to write basic literature, and they know to write an original article at the most. Okay, so they look whether you know the research methodologies well or not. They don't expect you to have groundbreaking randomized control trials in your CV. So do not stress yourself on the fact that, oh, this might be a common topic, this might be something less, this might be not impactful, but it's the idea and the initiative to write it which is more important. Uh, this actually I can skip because I did not get any visa questions at all. Um, and this is something which I again got. Language of your application. How do you write your CV and your personal statements? Um, as far as I've read a lot of CVs in the last 3 months, in the last 1 2 months, especially after results have come out, um, one thing which I understood was that a lot of CVs had repetitive words. You lose interest and concentration after reading through two experiences, and it was obvious that they had better, meaningful experiences down in the list. Okay, let's say someone is a great dancer, or let's say someone is a great singer. Okay, they write it as a hobby at eighth position or something. When they've contributed clearly so much to arts and something, there's something to learn from that. There's a lot of team effort that goes on. There's a lot of conflicts that go on. There's a lot of planning that goes on. Your meaningful experiences do not need to be only medicine. They can be anything. Okay, one of them can be medicine, the other two can be anything. For me, three of them were different. One was medicine, one was extracurriculars, and the other was volunteering. Three of them are three different activities. Three of them had three different um, outcomes, or learning experiences I had from three of them. So it is not a compulsion for meaningful experiences to be exclusively medicine related. It just has to be meaningful, and it should be passionate. That's the most important part of writing your meaningful experiences column. um, do not be mundane, don't be repetitive of words in the CV, because that kind of makes people lose interest in the CV as they read through it, and they have to screen 7,000 applicants. So it's not easy for program directors and the boards to do that. And I used bullet points when I was writing my CV, so that's a better approach as well. I have more slides in CV. Okay. Another thing is that when I was reading a few CVs, I saw these lines where they said went to the outpatient department and discussed with so and so, and that's it. You did not write what you discussed about or you presented about or what kind of cases you dealt with. So you are giving a very vague idea. Usually it's like you learned something, but what did you learn from it? Let's say if you went to the clinic and learned about lung cancer, it's different from went to the clinic and understood about the usage of PD-1 PD-L1 inhibitors in the cases of so and so cancers. It's more descriptive, it's more catchy for someone's eye, it's more descriptive, it catches someone's attention easily. That is how CVs have to be. They need to give the reader the understanding about what exactly you have done in that specific clinical experience. Discussed, presented, seen, handled, took. All these are adjectives with which all the 19,000 IMGs of us use. What did you take? What did you observe? What did you learn? Is the bigger question at the end of the day. If you do not write that, you are downplaying your own clinical experience. So please, that's one of the things which I've seen. Be specific about what you've discussed, presented. Let's say um, um, you have gone to a advanced heart failure clinic and you've met patients with LVADs. You can either write a discussed about managements of patients on LVAD, or you can write about certain discussion which are specifically like anticoagulations in patients with LVAD or something like that. So it's going to be more informative for someone who reads it and understands that you had more experience with that specific device, a specific treatment modality, a specific disease. So that's something. For personal statement, make sure that your personal statement is not like a ball bouncing off the walls of a room. It should not be multiple ideas written in the same page. It has to be revolving around a singular idea, and make sure that it's like a story. Okay. What do you mean? What do I mean by singular idea is what I'll talk about in the next slide. So usually the parts which you include in personal statements are why internal medicine, what exactly in internal medicine, why the US, what are your future plans, what do you want in a program, and what would you offer the program in return. These are the things which are very commonly used, or around which a person's statement is framed around. One thing you have to understand is internal medicine is not just patients, clinics, investigations, and everything. It involves a lot of other things. It involves guideline making. It involves quality improvement. It involves medical education. It involves global health policies. There are a lot of branches of, or tracks in internal medicine. You can love clinical education. That's a track in a lot of programs as well. So you have to be specific what do you like in internal medicine as well, because that is the level to which the competition has risen right now. You have to make yourself more visible and more pinpointed and accurate. A lot of people end up writing about internal medicine being, oh, this is a jigsaw puzzle I love to solve, multi-system approach. This is what probably 80% of the people are going to write. And you're honestly teaching internal medicine to a program director who has specialized in internal medicine, which is kind of a not such a great move to do, if I'm being honest. I'll show an article which was written by the PDs in Yale. So the scathing review of personal statements of the match in the last 5 years. Beautiful article. I don't know why they published it in Curious, but uh, I put up parts of the this thing so that you can understand where exactly or how exactly a personal statement should look like. And mine was completely framed off of that article. I made all the changes based off of that article. And personal statement has to be reflective of at least some of your personality traits, okay? Because it has to give them a flavor of what you are. Essentially, it has to speak to them. Uh, just one or two. You don't need to put all of them in that. If you feel that empathy is one of your most important traits, you're going to frame it around that. Helping patients, patient advocacy, improving patient health access, or all these things. Curious, you talk about research and your contribution to it. If you're a hardworking and responsible, which probably everyone writes about, but still, choose one or two traits and craft your personal statement around it. And these traits should not be repetitive, as in they should not be a part of your CV already. Okay. So usually the parts in the CV which you can't parts in the personal statement that you can't communicate in the CV are things like empathy and curiosity, because you just can't write those words in your CV. Rest of them, leadership, hardworking, responsibilities, are pretty obvious in your CV. But usually these which you can't give pinpointed examples about or are very elaborate adjectives are the ones which are difficult to mention in a CV. Those you can bring them into the personal statement and use the space of the personal statement to give your views about it. And again, avoid too many examples. You don't need to write 15 examples about 15 different cases in your personal statements. Write one or two, and that's more than enough. It just needs to solidify or build on what kind of personality traits you're talking about. Okay. Whenever you're filling in the CV and personal statement, put yourself in the PD's shoes and think, will you read it as a PD or not? It's as simple as that. You're writing a line. I discussed these case reports. Will a PD read that and get something from it? Probably nothing. If you mention something specifically, case reports of, let's say, post-hour AV blocks or something like that, that is when you will grab the attention of the reader, or else you will not grab the attention of the reader. You need to make your CV more particular and more specific. That's an important part about writing CVs. I just put this as a PD's frustration. Imagine you get 8,500 applicants for 30 positions. You need to have your own metrics to filter, send out invitations to as many deserving candidates as possible. Take time out of your clinical days and make sure to interview them, score them, discuss them, shortlist, and make a rank order list. In this whole process, do you think a line called discussing clinical cases or discussing case scenarios is going to impact in any way? Will they remember that? They'll probably not remember that. So make sure that whatever discussions and everything are happening, note them down while you're doing your clinical experience. Note what you've seen every day. Take a book, take a flip book. That's what I used to do. Take a flip book, put a date, write whatever you've discussed that day, so that at the end of the rotation, when you ask for a letter of recommendation, you can send them a list of things you've done with them. That's one thing. Second of all, it also helps you to write them in the CV. So please note your experiences and cases you've seen, whatever you've learned, the conferences you've attended, the morbidity mortality reviews you've gone to, all of these. Um, this is the question which I got. Honestly, I would not advise. No one, neither your seniors nor the best English scriptwriter in the world, can write your PS and CV better than you. Yes, might need grammatical corrections, grammatical errors, language polishing, better presentation skills are needed, all that stuff. But third-party agencies are notorious for changing your whole PS in such a way that you'll not be able to identify your own work. I've seen that happen with other people, and they made peace with it, which is sad because their own story has been overwritten by someone who doesn't even know them. The people who you can usually approach are including your seniors if they have time. If your friends who work in law and know drafting, they do a really good job at reading personal statements. Journalists, bachelor's or master's in English, your English teachers in schools, your librarians, family members who are native English speakers who live in the US or UK or Australia or anywhere. All of these people can do a better job than a third party agency because they know you in the first place. That is the most important part in editing a personal statement for someone. Um, this is okay. This is the article I was talking about. From personal statement to mission statement, editorial by Dr. Paul Bernstein, who's the current associate PD of categorical IM in Yale New Haven Hospital, and Dr. Doolittle, who's the current PD for MedPeds program at Yale New Haven Hospital. So, a very common scenario we see, you start off with the clinical case and how that inspired you in the field. They very clearly wrote, our own opinion is to do away with that trope completely. Okay. Medical education is complex and nuanced. Personal statement is not a proper venue to teach clinical medicine. You don't need to discuss about a case in detail because the person reading it and the person writing it, both of you know the management. Why are you writing it in your personal statement and wasting your words? There's no point. And this is one of my favorite lines. Epiphany from a single patient encounter is worrisome signal of short-sighted thinking when offered as an evidence of career selection. It is immature. If you're going to select a branch based on one clinical case, it is a very mature move. There have to be multiple factors which made you choose internal medicine. And this is a very common mistake which a lot of people do. They start off with the case and go on and weave the whole story around it and forget the essence of the personal statement at the end of it. This was the line which I was talking about. Avoid explaining the program director specialty to the specialties program director. Don't do that. That doesn't work. It's honestly bad. And this is something which I also told about. No need to rehash your CV, as in points which you've covered in your CV don't need to be in your personal statement. Points which are covered in your personal statement don't need to be in your CV. All these places in your ERAS application need to be different. Your impactful experience has to be different from your CV. Your CV's meaningful experiences have to be different from your personal statement. None of these should have overlapping things because once they start overlapping, it's going to be very repetitive when someone reads your application packet together. Minimize your family's medical history. Again, it's the same thing which they previously said. And conclude with a powerful summary. And this is also a good line. A lot of us end our personal statement saying, I want a program which is very supportive, has a diverse patient load, everything. Are there programs that advertise unsupportive faculty with few homogeneous patients with a narrow range of diseases that are poorly attended? Name one program. So why do you put it as your intention at the end? Think of something else, because all these have been done for years and years. These people have been there in those positions. They've seen hundreds and hundreds of personal statements. That's the reason why I took their reference very seriously, and I framed my personal statement based on this article, that this is how it has to be. It should not be explanatory, but it should talk about my view of internal medicine rather than the world's view of internal medicine. That's more important in this situation. Um, Again, I did not get a lot of questions on how do you select programs, but for me, geographical location was very important. I wanted to stay in the Northeast, so I was obsessed that most of the programs I applied to were there. I used the geographical preference thing. So, okay, signaling was something which people asked me. I summarized all the articles which I've used at the end. So if someone wants to take a picture and go and refer them, this is by Dr. Brian Carmody. If you follow him on Twitter, he does excellent analysis of the matches every year. Um, so his analysis in 2021 and 2020 when signals came for the first time, uh, ENT started signaling for the first time. So it was a big success because they had 30 signals. Okay. Uh, and it also brought down the number of applicants who applied for the branch and stuff. But unfortunately for internal medicine, what has happened is we had only 7 signals. It's insufficient. 7 signals are not enough for you to show interest. So I will future prospects for internal medicine signaling. I put a slide at the end. They're planning to increase the number of signals to 15 from the next match and cap the number of interviews at 15. That's the AIM recommendation for the next match. So this is what I talked about meaningful experiences already. And remember, impactful experience, um, when a PD opens your application, it's one of the first things that comes up right beside your EAS photo. It's the first thing that literally a PD reads or a person who's reading your application reads from their side. Okay. So you have to make sure that it gives you the perfect takeoff from there. So, don't make don't make it seem as if it's forced. Write something which is nice because it's one of the first things they're going to read about your application. Um, well, this is until 18th, 28th of September. And first of all, first 2 weeks is going to be rejections after rejections. And then one kind PD is going to send you an invitation and then it'll start. Um, I don't think I've gotten a lot of questions about getting interviews, so I think I'll skip this slide as well. But remember, always try to stay in touch with people who have matched before you and your seniors because people who have taken them from your college are going to take people from the same college again. That has been an established theory that has been working, and I feel that's one of the most significant um, ways by which you can get interviews. That's something which I've observed in this match, that people from our college, a lot of us got interviews from some of the institutions where our seniors were there in the past. So just like that, people from Osmania also would have experienced the same, where people from Osmania, if they're already there, newer people are also taken in the same college. So there's the trusted institution that is established because of that. So make a list of these institutions, and I would say use signaling wisely to make yourself more discoverable to these institutions. That made more sense in my head rather than signaling, let's say, Jacobi. They get 15,000 signals. I don't know how many signals they got. They got a lot of signals. So um, this is, I think these are all usually covered, during the interview season, like, things which you have to do during the interview and things which you should not do during an interview and stuff like that. But since I've not gotten a lot of questions on that, I'll skip it so that we'll have time for Q&A. So let's see. Yeah. Most of the rest of it is mostly going to be, during the interview season. I think now it's not that relevant because there are going to be more sessions in the future and there are going to be more people who are going to talk about it. For now, most of the questions which I think I tried to cover a lot of the answers for most of the questions which have been asked in the Google Forms, and those which I did not answer questions, I put them in the end so that we can go through them quickly. So this is the fresh NRMP data comparing how the rank order lists have been varying over the last 20 years. You can see that even though the average length of matched applicants rank order list is increasing, that buffer between um, unmatched and matched is also increasing over time. It means that people with 654 interviews are also matching now in internal medicine, which was not the situation in the past. Um, This year, the IMG rate fell by 0.9%, but honestly, 0.9% is not a lot. This is another slide which I wanted to show. Probable changes in the next year's match. There's going to be increased signals. Probably, nothing is confirmed. These are all suggestions from the Alliance for Academic Internal Medicine. There'll be increased signalings and there'll be tiered signaling where there'll be 3 gold and 12 silver signals, which is copied from OBGYN's signaling pattern, because they've seen that that has brought down the application numbers to programs drastically. And the ERA's application is going to become more and more specific. They're going to have more subheadings. They're going to have, I think, gap. You also have to explain your gaps in the ERA's application and stuff from the next one. And the next big one is interview cap. They're planning to cap the total number of interviews a person can take to 15. Uh, Whether these will be implemented or not is the second question, but these are the suggestions of Alliance for Academic Internal Medicine, which creates all these criteria. If you want to take a picture, these are all the articles which I've used in this presentation. Out of which I really, really want people to read the first one, the personal statement to mission statement. It was a beautiful article. I don't know how I found it, but somehow I found it. It helped me a lot. It helped gave me a perspective from, because everyone has different ideas about personal statements. Each one writes their own kind of personal statement. I asked Sai Kumar, he gives me one kind of input. I asked some of my seniors, they give me another kind of input. Everyone at the end of it says it's fine. But what exactly is a fine personal statement is becomes a question. So that article helped me understand what exactly a proper personal statement is. So the end. I will end before I'll eat more of your brains. That's my email address. If anyone wants to drop any questions, if I can't say I can sit and review all the personal statements and CVs right now because there's a pile of paperwork sitting ready for us. But I will try my best. Please, if someone wants me to look at the personal statements, I need you to give me some time. Uh, Before I'm telling that beforehand because I don't want you to feel that I've neglected your email. Um, these are some of the questions which have not been answered. Sai Kumar, do you want to go ahead and answer these questions? Actually, or we can rotate whatever whichever works actually.
If you
Yeah, we
are
can rotate
done
it.
with the presentation, we can start about the start the Q&A.
Yeah.
Meanwhile, if any of the audience you have any more questions to ask, you can drop them in the Q&A box and we'll try to get to them.
Thank you, Adarsh. It was a great presentation. To be honest, I loved your analogy with Courage the Cowardly Dog. And sort of resilience, I think, is one of the big differentiating factors in between our journey and say other journeys. But you have to stay strong to this journey and come out. I'm not sure about the 50 other people on this call, but I think everyone would have benefited if they have a flip book, like you mentioned during rotations during your conversation. A lot of points resonated with me. Of course, my journey was a couple of years before yours, but very valid and still relevant. Whether it's about making the most during rotations, expressing curiosity, and thanks for sharing that article about the personal statement. That is something I feel like sometimes we're not used to writing these essays, and when you go to external agencies for help, they may prop it up to such a level that it seems kind of not genuine. So having it reviewed by someone who's done that would make sense. That being said, yeah, we'll open the floor to any questions and yeah, any pressing issues, happy to answer. But I'm confident that whether it's Adarsh, me, Sai Kumar, Shanti, we're all very approachable, and you guys can reach out to us in case some questions still go unanswered after today's session. And we're planning to have more frequent sessions so that questions keep getting answered as and when they come up.
Yeah. Uh, for the questions that you mentioned, we can go by question. But before we go into that, I also wanted to thank Dr. Tangella or Adarsh. I've known him
Yeah.
for last 8 years, and I've always
It's
known him as a good teacher with good teaching skills. There's nothing new, and he like gets the point to you in a clear cut manner, which I've always appreciated in him. And again, the analysis that he does for the job that he's assigned to is always amazing, like he did today. So thanks for all the information and input today, others.
Don't you calling me Dr. Tangella is a little weird, but anyway, thank you for all the good stuff. Uh, I think one of the biggest things which I wanted people to take away from my presentation is the article on personal state. Please go back and read it because it's a it's just very simple things, right? It's the smaller things that matter in the match that will make you different from another applicant because most of us have the same kinds of LORs and everything. So um, it's slowly becoming the smaller things are becoming more and more important in the match. So make sure that your CVs and personal statements are written well and grab attention for people.
Yeah.
So let's see, while
And
we wait for questions,
yeah, go
Shanti,
ahead.
did any questions come up? Sorry, Sai Kumar, any questions come up already? Or I can take one of the questions on this slide meanwhile.
Yeah, sure. And you can go ahead.
So I was just looking at this question about networking as an IMG, and I think that is something really critical in this field. So one of my previous presentations on Let's Talk USMLE, I kind of wanted to focus on networking and stressed on the importance of social media. I know Adarsh mentioned about LinkedIn to get research opportunities, for instance, but I always stick by Twitter because personally that's something I found useful. Not only okay, I shouldn't lie. During my residency application, I didn't know what Twitter was. I may have had one Twitter post. I never used it, but during my fellowship application, I think Twitter definitely helped. So, guys, like we're not used to Twitter as much, but try to get yourself out there. But in terms of networking generally, I think in the US it's very important just to be in touch with people, know what's going on, rather than reaching out to them 1 week after submitting your application. So do your homework, know who is in which location. Like Adarsh mentioned about programs sort of creating profiles for residents where they pick residents from the same med school. They do give importance to that. So you have to do your homework and you have to do it in advance. That way you know who to reach out to and you can reach out prior. Ask people, hey, this is my application. Do you think my application matches with the profile of other applicants or other residents in the program currently? And if you reach out to them well in advance, they may be able to find some things that you can work on and incorporate in your CV. Rather than reaching out to them last minute in October and or August, reaching out to them maybe even now Jan Feb also better, but that way what you can work on in the next couple of months. I know it's a scramble most of the times. The last question: how early should I start ECFMG processing to get step 3? Um, I don't have definitive answer for that, but always work your timeline from your destination. So from when you want to do it and work backwards, and that way you can calculate and see how long it will take you. And similarly, even when you reach out to people, reach out in advance, a couple of months, half a year, 1 year also.
I have one suggestion about the ECFMG processing though. If you finish step 1 and step 2 and you're ready to give OET, who are you waiting for the ECFMG processing? Just finish it, irrespective of when the match is. I applied for last year's match. My ECFMG certification was done in 22. I could have done it last year, but I did not want it to stay and lurk like a scary thing right before the match and all the delays which happen. You've seen a lot of things which happen. People complain that it's getting delayed and everything. So finish it at the earliest. Once you finish step 2, finish OET and just submit your ECFMG app, certification. You'll be done with it. Um, so yeah, because I don't think people who got certified last year also got it till 24 December. In 22 also we got it in 24 December. The expiration date was the same. So it really doesn't matter. You just finish it at the earliest possible whenever finances and circumstances are helpful for you.
I can take the question about the study routine for a third year student.
Mhm.
So I was someone who incorporated step prep very early on during my med school, from second year and third year. So I would say starting off with the basic resources like Pathoma and BNB during your second year, and using Sketchy for micro and pharma is going to help very well for your med school exams as well. So that eventually, since step one is now pass or fail, I think you'll be able to better plan your exam in your third year, in end of third year or the beginning of your fourth year, so that you won't take much time to finish the rest of the requirements once you're done with your med school. So I think it's pretty much doable if you can finish your exam in third year or the beginning of fourth year. It would help for your final year exams as well. Just the basic ones like boards and beyond, Pathoma, Sketchy, and you can start studying systems on in first aid book as well.
I
Yeah.
think we have a hand raise in from one of the audience.
Yeah.
I'll give the mic and see if that's what. Uh, yeah, is it Mr. Sakir?
Hello, can you hear my voice?
Yes.
Yeah. Hi, sir. Thank you for the session, first of all. My name is Krishna Saket. I'm from 2K17 batch in Usmania. I have a few questions that I wanted to ask. I forgot to ask them in the Google form, and I wanted to ask you. First thing, about the signaling. Even in one of your slides, you mentioned that there was something about this year's biggest loser or something. So has signaling had a negative impact on either IMGs or AMGs? Has that been the case? I can't seem to understand. There are people who
Okay.
say that it has a negative impact and that it is actually causing a lot more issues and stuff like that. But I didn't seem to understand how that is the case.
So I can take your question because
Yeah.
so honestly, none of us knew how signaling worked this
Hmm.
year. Neither the programs understood, neither we understood. Like, how do you prioritize a signal? The programs did not know because
Mhm.
it's always a bunch of programs getting most of the signals and a bunch of programs getting average of 5 signals. So
Mhm.
what we thought signaling would be helpful for us in a way is that this is how we signal this year. Two programs which are a little out of our reach, three programs which are completely under our reach, two programs which mm, are not we can do better than the two programs, something like that. Okay, so
Mhm.
this is how we split. But those two programs at the bottom end already knew that we were signaling them as safety nets, so they did not give us interviews. Okay, fun fact. So we did not get interviews from those two places. Where I was surprised, like people with not so great profiles also were getting interviews from those programs. How come I'm not getting? I signaled them. It makes sense because the PE doesn't want to give them interviews because he or she knows that you're not going to rank them high. So what's the point of giving you an interview? It's all so signaling this year. I don't think it had a really bad negative effect or something, but 7 signals is not enough to actually show your real interest in programs. And that is one of the, and it really did not change the number of applications which each program has gotten as well. It did not bring it down or anything. The intentions of signaling were not met with 7 signals. So yes, at the end of the day, somehow only big signaling was the winner. Small signaling did not do did not do much of any difference. And the programs which usually gave interviews to people, let's say if this year a person A has been given an interview from a program, the profiles which the program has taken in the past are also similar to them, irrespective of signaling. So it did not really take signaling into account that much as what we were expecting. We were expecting it to be a knock on their door and entry and all these things. It's going to be easier. We're going to get interview, at least an interview from the program and stuff. But no, um, it did not. As far as I know, it did not exactly go like that in this match here, even though all of us utilized signals. But because from the next match, they're going to cap interviews at 15 and you're going to get 15 signals, it's going to be a game changer. If you want to read more about it, you can read about how signaling has changed ENT match. signaling has changed OBGYN match. Both these matches have tremendously been affected by signaling, and the number of applications have come down drastically because you have 30 signals. So that's if you apply for 40 programs and you signal 30 of them, if they're getting if they're getting a if they're getting if they're getting if they're getting an applicant who has not signaled them, it means that they are their 31st choice. Why will they give them an interview? Okay. So only big signaling is going to work. At least 15 signals should be there. If that's what we thought at the end of the match as well, because 7 really didn't make a lot of difference.
Yeah. The second question is from one of your slides. Can you explain the ROL concept? Can you elaborate on that? Because I don't seem to have understood that particular
Oh, I mean, it was
gradient
just.
between.
So go ahead. What didn't you
No.
understand?
The ROL that you mentioned, that there is the concept of length of match. Is it based on the? I don't seem to understand what exactly does that have to do with the rank order list?
This
Yeah,
Yeah, the table, the comparison, I
the
think.
next one, the comparison.
this one?
Yeah, that one.
Oh, no. I was just talking about how so it has been statistically there are a lot of studies which go on NRMP data every year, right? So they've understood that people with 4-5 interviews, which are not exactly the average matched applicant numbers. Okay, usually the matched applicant numbers are standing at 7, their rank order list. But it is said that people with, let's say, 4 or 5 or 6 interviews are also matching at a higher rate when compared to the past. So that buffer interval between 3 to 7 doesn't mean that you're not going to match if you get that many number of interviews. The possibilities are dwindling and it's not above 90%. That's what they wanted to say. Nothing really significant. It's something which everyone knew already. Like the graphs and stuff, if you go into the 2022, 2023, 2022 analysis, they have like a graph based analysis. If you can look at, that's where they write about, at 10, your percentage of matching is above 90%. At 8, yours is this much. 7, yours is this much. So,
Can
Remember,
you
guys, take this
yeah.
information with a grain of salt because it's overall and not like for IMGs,
yeah.
USMGs, etc. So yeah, sorry to cut you off. Go
This
ahead.
is
Yeah.
this is for non-US IMGs, but then it includes
Okay.
like green card holders as well who are non-US
Okay.
IMGs. That's always a bias which we have. So
Okay.
Yeah,
I think the
that is.
questions are.
Yeah, I have one
Yeah,
other
go ahead.
question. I actually have two other questions. I'm sorry, I should have mentioned all this in the Google Forms.
Yeah, we can just restrict the time to 2 minutes for each answer so that we can answer some other questions we have, since we were thinking only for 8:45 to respect everybody's time here. Others, yeah,
yeah,
you
So
can go ahead and ask. Yeah.
two questions. I'll just mention them back to back. One is audition rotations. Do you think they're worth it? Because I've seen people pay around $3,200, $3,700 for those. But I've also heard American AMGs say that people who are American med students, they go and do audition rotations with the PD that they're interested in their third and fourth years. They have 4 selective and 5 elective, 4 selective and 4 elective rotations during their fourth year, and 4 of those they use it for program director rotations or audition rotations in the program that they're interested in. And second question is, what does the J1 versus H1 issue, which is that you have to do a J1 waiver stuff and everything. And I understand that there's like pros and cons of both with respect to fellowships and all that. Do you think it really matters when we are putting our rank order list to sort of change it in a way that would favor programs that have a history of H1B sponsorship? Those are my 2 questions.
I think I can take at least one of the questions. So I'm on H1B currently, and so I can answer that question. So while I was ranking, it all depends on what you want down the lane. Like you mentioned, you wanted some fellowship. If you already know about the fellowship stuff, just to give a brief, So if you're planning for fellowship, be it internal medicine or after neurology or after any residency that you get into, from my understanding or from my knowledge, I would recommend taking J1 visa. So because most of the fellowships, unless you are exceptionally good, they wouldn't offer you H1B visa for fellowship. I don't have the exact numbers, but from my understanding, at least 90% or 93% of the residency programs offer J1, just to have an approximate idea, and maybe the 7% offers H1B. So this
Hmm.
ratio gets worse when you apply for fellowship. Maybe
Hmm.
98% apply for, provide J1, and the 3% give you H1. So it doesn't make sense to be on H1B visa for your residency, be it 3 years or 4 years. And if you want to do a fellowship, you have to go back to J1 again, and you have to
Right.
still do a waiver visa because you're on J1 visa. So
Hmm.
if you're having at least, this is the advice I've been giving people, if you at least have 50% or 30% thought of doing a fellowship, I would recommend going with the J1 visa, even though the program offers H1B visa. So
That's that.
if you
Thank you
have,
so much. That is
yeah,
actually really interesting because I've been told by some people that this issue with fellowship bottleneck is actually more like a theoretical issue. But thank you for mentioning that. I think that's
yeah.
very useful.
And the other point is also during your, if you are on H1 visa, you pay more taxes even during residency compared to your J1 fellow counterpart. So it doesn't make sense if you don't want to, go directly to a practice after your residency and apply green card and pay your tax, pay extra taxes during residency on H1 visa and go back on J1 visa and then do the waiver still. So it doesn't
Hmm.
make sense if that,
Hmm.
if that answers your question. Uh,
Definitely. Thank you so
A
much, sir.
limited
Thank you.
perspective I can share with respect to fellowship application is like Sai Kumar said, there will be fewer programs, but all the like say Ivy Leagues and the big places, UCSF, etc. They also mention on their website that they sponsor J1 and H1B. But still, it would narrow your options if you are on H1B. I feel, I mean, yes, going through the fellowship match a couple of months ago. So yeah, that is something to definitely keep in mind.
from my understanding, if you're exceptionally good, everything is possible in United States. I've seen people, I've seen programs creating a separate track if you are interested in something like global health program or global health initiative, something like that. Everything is possible in US, but you have to
Hmm.
have that competitive application for them to see the worth in you and then give you that H1B visa or create that special track. So if you're that competitive or that confident about yourself, you can do H1 and then think about fellowship. But just to be on the safe side, J1 is not the words visa. All of us are on J1. Most of us are on J1 visa, so it's a good option to consider J1 rather than H1 if you have plans of fellowship. So that's the one question. And for the other question you mentioned about uh, audition electives, I've never heard about audition
I
electives.
can I can talk about that if just a
Yeah.
brief idea.
Yes.
So you were asking about away rotations which US people do during the match or
Hmm.
before the match so that they want to match there, right?
Yeah.
Uh,
Yeah.
the chances of so first of all, every rotation we do is away rotation. Okay,
Hmm.
we are going there to audition in front of the PD. You're going to approach the PD in a way, and you're going to talk to the PD and stuff if you're interested in the program.
Hmm.
So there's nothing called away rotations for IMGs because all our USC is kind of away rotations because our home institution is not here. Second of all, what you're talking about, the 4 months which they do is a sub-I. It's not exactly an elective. They do sub-internships. They work almost like an intern at an intern's capacity.
Hmm.
That's when the PDs look at their work capacity and give them an interview and stuff. So it's not that common for IMGs to rotate in November and a PD seeing their capability and
Absolutely.
giving them an interview because
Hmm.
it's barely a month and you're not working at like a sub-ICE level or something.
Hmm.
But again, as Sai Kumar said, anything is possible. So if you can talk to the PD and if you can express your genuine interest, that might be possible because um, at the end of the day, they'll be looking at you as a person first and then on paper next. That's always beneficial. So there's pros and cons, but it's not a guarantee of any sort. People pay, but you can't go to University of Maryland and expect an interview from them. You have to be a little rational about where you rotate as well. Let's say if you rotate at UMKC, you might have a chance. But if you go to, let's say, Wheel Cornell and expect an interview, that's not something which is really feasible because they usually don't take IMPs. So maybe there's a chance, but usually what they do is sub-Is. Away sub-Is is what they do, and that's where they prove that they can work at the level of an intern right after medical school. So
Yeah, so we have 10 to 15 minutes left. Did that answer your question, Saket?
Yeah. Yes. Thank you, sir.
Okay. Yeah, all right. So I have a couple of questions for you, others basing on your presentation today, and given the special situation or the match process that you went through, because I don't know if you noticed it, but others completed his graduation in 2021 and then thought about USMLE, did all his observerships, never did any electives, but also had good LORs from my discussion with him in the last 2 years. So my question to you is, because people have been asking me with this weird recent 2 year rule to complete their internship after they complete their med school. People were reaching out to me saying that, hello, since with this 2 year rule, I completed my step one, step two, took some time, I only have 3 months left. Should I still go for electives in that 3 months, try for electives, or just get my graduation, go to US, and then do all observerships back to back and then apply? So I was always telling them, if you never have a choice, like to extend your like we the internship like we used to do it before, you have to graduate, and it's okay to do observerships. You will still get a good LOR from an observership, but the only thing, same I was telling them, elective versus observership, the LOR you get would describe almost all things except for the clinical interaction with the people, with the patients, but otherwise your daily showing up, and you're being punctual, and you're being active, your clinical knowledge, your assessment, all that, they're all same for an observership versus an elective. So my question to you is, what's your take on getting an LOR uh, from an observership versus from an elective?
uh,
uh, I don't know
uh,
whose mic that
I-
is, but if you can.
so
Okay.
if I'm being honest, I feel that a lot of people downplay the amount of work people do in an observership because the name is misleading in itself. It's as if you're seeing what is happening in a hospital, but then you're actively involved in a lot of things. Let's say, for example, when I was in Cleveland, I was involved in tumor boards, I was involved in morning conferences, I was involved in guest lectures, I was involved in conferences happening in the hospital. Uh, I was going on rounds, I was having inpatient, outpatient exposures. Actually, I mean, it's not exactly right to let people go and examine patients, but they used to let me talk to patients and stuff so that I can discuss things with them. So, as I said, I think a very important thing which they look for is how dedicated you are in that rotation. Are you just there because you want USCE, or are you there to actually learn something? There are two kinds of people. They have two different approaches. If you really are there to learn something, it's pretty obvious. They'll know that they've been professors for 30 years now. Um, and how do you show interest is, first of all, be on time. Just, at least comb your hair, dress up properly, and go into the hospital in the morning. Don't take too long of breaks in the afternoons or in things like that. Come back on time. Uh, be friendly and formal, I should say, like a balance of both of them, not exactly like rigid formal how we are in our medical colleges, but open to discussions kind of formal approach is very important in US hospitals. Um, and if there is a team of people, this is something which I really enjoyed when I was in the CCU rotation in one of the hospitals. It was also an observership, but we used to select a topic, and we were three medical students there. We used to present one different kind of topic every 3 days. It was a complication of a certain procedure in our patients as well. So we used to take that topic. Let's say one day the topic was thrombosis post PCI. and the other day my topic was AV blocks post hour. So the things like these, when you're present, you can write it on your CV as well. So um, I think a very important part is noting down all these somewhere. Do not forget to do that because in the whole mess of writing a CV, you'll forget a lot of things. So that's one thing which I feel, and do not doubt. Observerships are not exactly equal to electives because you're missing the patient contact part for sure. But when you have no alternative, you can always
Yeah.
get your best out of it.
Yeah, given the current situation that most of the electives are offered through VSLO and they have this 2-year rule to complete our internship, most of the students tend to do their exams during their internship. So that will give them this just narrow time to come to US and do the electives, but they have to have some electives, which is also again another struggle to get electives. So this is one thing people have been asking me. So I was telling them it's okay to do observerships. My formula has always been clinical university based clinical electives greater than university based observerships greater than some private elective or some private clinic elective or some private hands on blah blah blah. So this has been my recommendation for people, if that makes sense.
And also
And
when you write your CV, you do not write it as observership at so and so institution. You write it as visiting medical graduate at so and so institution. The
yeah,
minute you write it as an observership, you yourself are downplaying what you've done. Okay, it's not
yeah,
just an observership. It looks much more formal if you write it as visiting medical graduate in so and so department of internal medicine. So you're a medical graduate visiting the hospital in so and so department. You're not lying to them. So that kind of you know gave a better look for my
yeah.
CV as well.
The other question I have for you, and will restrict the answer to 2 minutes because of the time constraint.
Mhm.
The one recent change that has been made in the ERAS application compared to our previous was having 10 meaningful experiences for all the experiences that you have.
Three,
Uh, in just three.
yeah, out
We
of 10.
had we had Okay, I might be confusing because when we were doing our application, we had three clinical experiences or 3 or 4 clinical experiences, and then personal experiences that and volunteer experiences all separate. But I was reading through, and it said all this should be restricted to 10. Is
Yeah,
that correct?
yes, the
Okay, and
total
my
number of
question,
experiences. Yes.
yeah, so my total number is 10. How many would you say, like, for example, how many personal experiences would you include? How many medical experiences or clinical health care related experiences would you include? Or how many volunteer experiences would you include? What would you think is the good percentage of each?
Um, I think for a well-rounded application, it should be around 60% is usually medicine, 60 to 70% of it, because that's primarily why you're applying. Um, 10% can be your extracurricular activities, hobbies. One experience usually can be for that, and two can be voluntary activities. That's kind of how I broke my experiences down to. It was 7 plus 1 plus 2, if I'm not wrong. So that should be actually
Okay.
pretty decent. 7 plus 1 plus 2 or 6
Yeah.
plus 2 plus 2, however you want to do it.
Okay.
Um,
Yeah.
yeah, I think that should
Okay.
be decent.
And if you can go back to the, thanks for answering the question. If you can go back to the questions, there are
Yeah.
two other important questions which we missed, I believe. And yeah, the first one I see is, which is unanswered, is failed step attempt, low scores, and how do I improve CV and research? Uh, Dr. Chaha, would you want to take this one? Comment on failed step attempt and low scores, and how do I improve CV and research after that, and maybe chances of matching with a failed step score.
Yeah, to be honest, red flags are red flags, but you got to look beyond and try to improve. And then you'll have to sort of attempt to compensate that with research. I know others mentioned about how to get a research position. This is the ideal time when people are getting out of their research position, those who matched freshly. I would say in terms of research, better than being a research collaborator sitting in your basement, if you need to improve your CV from a failed step attempt, better to put yourself out there and actually do in-person research, work with the principal investigator. But I personally don't have experience doing that, like J1 research. But from people's experiences, I've learned that, two PIs are very different. No two PIs are the same. So make sure wherever you're going, the only thing I could say is make sure your PI is someone who's really supportive. Look at the research output of the persons who worked under him in the last 1 year. So are they getting first authorship? How many abstracts were they able to put out? Were they able to publish anything? Before you commit to a PI for an extended period like 6 to 8 months. I hope that answers the question, but I know it's a incomplete answer because you'll probably have to build your CV from scratch, keeping that in mind, and sort of push your application forward. Yeah.
That's
I've come across, yeah, sorry, go ahead,
no,
Adarsh.
no, no, go ahead.
Yeah, I've come across 2 to 3 applicants who said they have failed attempt and they were really worried about, and they were asking me questions like, would I still be matching? My answer was, well, given the situation where there are a lot of applicants from around the world who have better application, they probably will choose that person over having an applicant with a failed attempt. But for you to show that that failed attempt is just like one-time mistake and you have much more to offer rather, I mean, in compared to that failed attempt, you need to have a better CV, better research, show up, maybe target few specific programs, like 4 to 5 programs, and show them what you're worth. And that would mask the failed step attempt and it wouldn't bother, and you still have chances of matching. But again, it should be a targeted approach compared to casting your net widely like all the applicants do and expecting interviews that way wouldn't be more fruitful for you, is what I've been telling. And others, you can continue.
No, no, I was just going to build on what Dr. Chaha just said, that a lot of PIs do prospective research. That's one thing you have to remember while applying for positions. Prospective research does not churn out articles once in every 3 months. They do it in once in 2 years, and it's going to be a groundbreaking paper. So if you're there for 6 months, your name is going to be in the acknowledgement section, not in the co-authorship. So you have to, make sure to go through the PI's work and the volume of work and how much they're letting their, research assistants publish intermittent results of the studies or something like that. So
I think we can take one question from the audience.
Yeah, Mukta has her hand raised.
Yeah, you can unmute yourself now, Amukta. And
Okay. I hope I'm audible.
yes.
Am I okay? Okay. So hi, sir. Thank you for the meet, for organizing this, and for taking your time for us. I'm Amukta from 17 batch Osmania, and adding on to what Sai Kumar sir was discussing right now about electives versus observership and all of that. So my add-on question to that is, if you had to pick between, let's say, a clinical elective versus a research elective at some place like Hopkins or a good institute, and you have like two US clinical experiences. The third one you will have to pick between an elective or an observership versus a research elective. What would you rate higher?
So you said you already have one clinical experience, correct?
Yes, sir.
Okay. Clinical experience, and you said you also have another research experience?
No, two clinical experience. Like if we had to satisfy minimum three clinical experiences or get three LORs, and if I have two clinical experiences, can I pick research elective as my third?
You can. That would also make it a complete application, saying you also invested time in learning about clinical research. I don't think it's frowned upon.
it's
But yeah, you can answer that as well, Adarsh.
it it's not frowned upon, but the thing is, how much will you learn in a month's research elective is the question. You know, because there's so much to learn from a research software. It's been 7 months since I started learning one. I still haven't understood 80% of the commands in it. There's so much to learn about research processing and biostatistics that a month will never do justice to that. Um, on the other hand, if you want to actually if you have pretty decent scores and if you're fine with, skipping the research elective, I would rather advise going for the clinical elective and collaborating for research with other people and publishing parallel to your clinical experience. That's what I did. I had the option of taking a year-long research or going and going on doing observerships. I took the other route, and parallel to that, I published. So that's something which you can always do as
Yeah.
well, because a month-long research elective, I don't think you're going to learn a lot. It's
Yeah.
it's very
And
less.
you should also talk to people who have already done it. I've come across people mentioning about this research elective at John Hopkins,
Yeah,
but I'm not sure what they actually do there and what they actually get out of it. I've heard that they can also go with the attending to their clinic, and they can rotate with the attending in their clinic seeing the patients. But again, it's observership like cut down to half, and then doing mostly helping them or gaining exposure to research is what you can mention in your CV. So everything is about selling yourself in this application. So whatever you do, like Adarsh was telling, you can say clinical observership, or you can say Cleveland Clinic clinical experience. So I would prefer the second one rather than downgrading yourself and saying observership. It's all about selling yourself. Are you getting the point? So even with this research elective, I don't think you'll have much to sell yourself from that research elective, but you can talk about the John Hopkins clinical experience that also you also got during that research elective, and also mention that I got exposure to research. But I would prefer doing an actual observership compared to a research elective here at John Hopkins, from my personal understanding, because you'll have more to talk and more to sell with an observership rather than doing this research elective. And I take this with a grain of salt and talk to people who have already done it. If they mention that there's much more in this elective rather than just getting this exposure to research, I would prefer doing that again. And I don't have an exact idea of what they actually do at this elective.
But then again, if you don't have any other observership lined up at, say, an IMG friendly program, and if you're looking into just third party rotations, you could prefer the Johns Hopkins elective over that, is what I think.
agree with
Okay.
that.
Okay. So this will be
Maybe
your
we
last
can
question
maybe we
for
can take one
today.
last question.
Yeah.
Uh,
Okay.
the Danya raised her hand.
Yeah. You can unmute yourself now, Danya, and
Hi,
ask the question.
hi. Can you hear me now?
Yes.
Yeah, hi. I just wanted to. It's not a question. I just wanted to add to what you guys have just spoke about. Answered Mukta's question. So I'm currently doing my research elective here at Hopkins. So I'm two
Awesome.
weeks in, and honestly, I don't. I would 100% prefer a clinical elective or clinical observership experience over this, because these 2 weeks have just been. So I'm working in the wet lab, so it's just been me observing mostly my lab mates doing PCRs and ELISAs and some mice experiments. But I don't think this is something that I would like to do going forward. So I don't think this is like something that I would like really. It's not really like a great learning experience, to be honest. It's nice watching, but it doesn't really align with my goals. So yeah, I mean, I
Yeah.
think it comes down to what you want to do further. My attending is he's very much interested in research. Along with that, he also goes to the clinic, and as Pasya was just mentioning, we were allowed previously, I think maybe a year before or so, but we're not allowed to go to the clinic anymore. Because I think
Okay.
the system here, they kind of got to know that the IMGs are trying to get in through the research elective, and then they're trying to just get some clinical experience too. So they don't allow
Okay.
that anymore. Because even I myself asked my attending if I can go to the clinic with him, but then he did not allow me to do that. So I just wanted to mention that. Yeah, thanks.
Awesome. Thank
Thank you.
you. Thanks for the real-time information and insider
And
information.
yeah, that
Thank
should
you so much
answer a
for today's
question.
talk.
Thank you so much, Danya, and thank you so much to Shanti and Sai Kumar sir for this meet. It was really helpful.
Awesome. Nice. And I think we'll postpone, I mean, we'll relay all these questions. I think Aparna has one more question, but we would prefer if that question could be answered asked in the Instagram takeover by others.
Yeah.
I'm sorry, because of the time restraint and having respect for all the people's time here, we'll stop the session for today, and we'll have time for like 1 minute time for each speaker and organizer here to speak about it. But my one last line, or what I would provide you with for the takeaway, is all the applicants, whatever stage you are, or whatever phase of preparation or USMLE preparation you are, I always was telling people that plan things retrograde, meaning target a match, like be it 2024 September, 2020, I mean 2024 September, or 2025 September, or 2026 September. Plan things retrograde, not progressively, meaning if you're planning for next year's match, like September 2025, make a timeline, like for example, okay, this is when I need to have all the application or documents ready, so I need to complete my step 2 by this time, step 1 by this time, elective somewhere this time. And also keep a download the era CV today, like tonight. Download the era CV and you print it out and see what all columns that still needs to be worked on for your application. I know people would have some volunteer experiences, but they wouldn't have any research experience. Some people might have the other side, I mean, have research, but wouldn't have the volunteer experiences. So if you download the ERAS application, that is your end goal. So that is what you need to fill out at the end of the day, applying for match cycle. So keep this downloaded application, ERAS application, ERAS CV on your side. Try to plan things retrogradely and see what all are the things in your CV that needs to be incorporated or worked upon retrogradely in the time that you have. And for even for exams, make a date, arrange it, schedule an exam, and then work on preparing, rather than indefinitely preparing and not having a scheduled exam date. That would delay your exams by months, believe me. So these are the big things that you need to take away from this presentation from my side, from today's session. And Dr. Chaha, if you want to go next.
Yeah, guys. One thing I want to tell you all, like this is not a sprint; it's a marathon. I'm still running. Others will still have to run. You guys are still running, I know. So pat on your back to each of you for being so resilient. One more thing this journey will teach you is the importance of giving back and gratitude. So when you come up, I only want you guys to help others who are also coming up in this journey. Thank you, Adarsh, for your time today and your experiences. But I look forward to meeting all of you again in our next meeting.
Dr.
Sorry,
Pasha, your mic.
if you
You
wanna,
might.
yeah, sorry about that. And awesome, thanks, Vinay and Nav, for joining today and having us time with us. And Dr. Adarsh, or if you wanna go next and end your
Close the
day.
session. Oh, Shanti is also there. So, do you want to go before me, Shanti? Just
Yeah,
whatever
in
works.
terms of advice, I really don't have much to offer. I'm just really grateful that we got to do this session. And as someone who's still in the process, I'm learning something new every day. And like Dr. Pasya said, planning early definitely gives you a head start. So if you're still in your med school, I would suggest doing that. And just feel free to reach out. We're all willing to help, and we might take our time, but it's always nice to give back. So yeah, that's it.
For me, I think it would be sit and answer your difficult questions and introspect what you want you to be on your application, because that matters a lot. They don't want to see one person in the interview and a different person on paper. They have to be similar. So I know we don't have experience with writing personal statements. We don't do it usually as college applications and stuff. So when you write it, just make sure that it's reflective of you. Don't force it, and start, as everyone is saying, give yourself a early head start so that you not get lost in time and you not have to rush in the last moment. And that way we can also help you because you can give out drafts early on, we can correct it, you can refine it. And I made 15 drafts of my question statement before it was finalized. So that's how it's going to be. It's not going to be done in one sitting. So it takes a lot of time and energy. So be prepared for that. And best of luck to all the future applicants. And I hope to see you I hope to see some people next year in my program as well.
Yeah, and I
Thank
just
you.
realized I need to add something. And mentioning about Shanti, we're really proud of what she has achieved so far. The initiative or the energy that she brings to this initiative and what she's achieved so far, working with seniors, working with a fellow, the residents. She's working on her CV really great, and she had an amazing step to score. We have another session coming up on dedicated speaker, Shanti, talking about how to score 265 plus on step to CK. So we are excited for that. That would be our next session. And
Thank you.
yeah, like we mentioned, we are all proud of what you've achieved so far, and all the best for you for your upcoming match cycle. And for the other participants today, all the best for everything that's you are working on at any stage or whatever stage you have been so far. And the other thing I wanted to mention is whatever questions you have left, or others will be taking over the Instagram starting now. He'll be available for the next 24 hours, something like that. He'll try to answer the questions that we get on the Instagram. And hopefully, if you have any questions left over, you can ask the questions there. And Aparna, sorry for not providing the mic and because of the time restraint. And I think you can still get the question answered in the Instagram takeover. And with those words, I'd like to end today's session. And thanks everyone for joining. And thanks Dr. Jaha, Shanti, and others for your time. So we'll see you again in the next session.
Thank you. Thank you so much.
Thank
And
you.
everyone have a great
And
day.